Assalamu alaikum and good evening to you all. Welcome to the Health Talk on Acute Medicine, organized by ACB Bangladesh Chapter and supported by Bangladesh Society of Medicine. Today we have come to the 15th episode of our Health Talk series. On this episode, we are going to talk about a very important topic in medical science. Today we are going to talk about acid-base disorder. To talk about this important topic, we have Dr. Raihan Rabbani sir with us. He is the consultant ICU and internal medicine Square Hospital. To chair the session, we have our very own Governor-elect of SB Bangladesh chapter himself, a living legend in the field of medicine, Professor H.A.M. Nazmul Ahasan sir. He is the former president of Bangladesh Society of Medicine. As the panelists, we have two most renowned physicians of our country. Firstly, we have Dr. Ahmed Mursel Anam sir. He is the associate consultant, critical care and internal medicine, Square Hospital. We also have Professor M.D. Golam Kibria Kawser with us. He is the former professor of medicine, Dhaka Medical College. To moderate today's program, we have the beauty with brain, Dr. Chowdhury Tamanna Tabassum. During the live session, you can ask topic-related questions on the comment section. We shall try to answer them in the question and answer session, which will start right after the presentation. So, without doing any further delay, let me hand over the session to Dr. Chowdhury Tamanna Tabassum. Dr. Chowdhury Tamanna Tabassum.
Thank you, Dr. Prince, for your brief introduction. Assalamu alaikum and good evening to our honorable chairperson, our respected brilliant speaker, panel of experts, respected teacher, and audience. First, let me introduce myself. I am Dr. Chowdhury Tamanna Tabassum, specialist of Medicine Department of Square Hospital Limited. I'll be responsible for moderating this session for tonight, and I can see all my favorite teachers and mentors here tonight. So I'm very glad to welcome you all. Tonight, we are going to discuss about acid-base disorder. Actually, blood needs the right balance of acidic and alkaline compounds to function properly. Kidney and lungs works to maintain the acid-base balance. Even the slight variation from the normal range can significantly affect on your vital organs. As Dr. Prince already introduced our speaker and panelist and chairperson, so without doing any further delay, I would like to request Dr. Raihan Rabbani sir to start the session. Dr. Raihan Rabbani sir.
Thank you, Dr. Chowdhury Tamanna Tabassum, Honorable Chairperson, distinguished panelists, and all the listeners. Welcome to my sessions today. So today, I'm going to talk about arterial blood gas, its interpretation, and relation with acid-base disorder. So today's presentation, we're going to start now. So first of all, I want to just give a brief introduction about ABG. So what is an ABG? So ABG, as we know, it's an arterial blood gas. It's drawn from the artery, and usually we draw it from radial artery, femoral artery, or axillary artery. And we try to avoid to draw it from brachial artery because brachial artery is end artery, and if there is a dissection or blockage of brachial artery, we may lose the forearm of the patient. It's an invasive procedure, so we have to take it seriously. And it helps in assessing respiratory status, also helps in assessing acid-base disorders. And to analyze the acid-base disorders, we also need a contemporary electrolyte value to analyze the acid-base disorder properly. So this is a very favorite person of mine. So Einstein, all of you know him. So one of his quote, the world is not dangerous because of those who do harm, but because of those who look at it without doing anything. So ABG was like something that to me, that I was looking at it, but I didn't understand and I didn't act. But when I started understanding ABG, so and I started acting on it, and the patient, I think, got much more help from it. So today's session or today's lecture is aiming on that we can look at ABG, understand few things, and then act on it. So ABG, what we have in the ABG, what are the basic things? So we can understand the pH in the ABG. We can see the pH of the blood. We can see the partial pressure of carbon dioxide, partial pressure of oxygen, and the bicarbonate is calculated there. The other three parameters that we talked about, it's mostly measured, the bicarbonate is calculated. And from there, we can see the base excess, oxygen saturation, all those things from calculation. And some ABG machines also gives sugar values and also gives other values like lactate. So that varies from machine to machine, but we will not concentrate on those things. The acid-base relationship is very important in our body. The relationship is very critical for our homeostasis, and any significant deviation from normal pH range are poorly tolerated and may be life-threatening to us. And this acid-base relationship is achieved by the respiratory and mostly the renal systems, and it is maintained in conjunction with the buffer systems. The basics all of us know, so I am not going to get deep into those things. So what are the respiratory component of acid-base disorder? The respiratory component is manipulated by the lungs, and if we think about carbonic acid, that's produced from the carbon dioxide that is produced in our body, and approximately 98% of normal metabolites are in the form of carbon dioxide. And the excess carbon dioxide is exhaled by the lungs, and by exhaling and retaining the carbon dioxide, our lung maintain the normal pH of the body. So we will think about the carbon dioxide as an acid in acid-base disorder. The metabolic component is mostly manipulated by the kidneys, and the kidney mostly manipulate the bicarbonate in the form of sodium bicarbonate, and the kidney can excrete hydrogen ion in the urine, and it reabsorbs the bicarbonate into the blood from the renal tubules. And the active exchange of sodium for hydrogen ion between the tubular cells and the glomerular filtrate that helps the kidney to regulate the acid base. So what we have to know here, that the changes that lungs made, that can be made within minutes, but the kidney takes more time to make changes in acid-base disorder. So that any change in the carbon dioxide and any change from the lung, that will happen within minutes. Compensation will also happen within minutes, but for kidneys it will take about 48 to 72 hours to completely adjust the acid-base disorder by the kidneys. So the normal values of the ABG, what are the normal values? So if we look at any normal values, there is a range. But in case of ABG, we'll know the range, but for the calculation, we'll get the median values. So the pH, normal pH is 7.35 to 7.45, and for the calculation, we'll take 7.4 as the normal of the pH. The PCO2 is mostly from 35 to 45, and we'll take 40 as normal. And the PO2 is 80 to 100, that is normal. Bicarbonate is 22 to 26 is normal, and we'll take 24 as the standard value for the sake of calculation. Base excess is from -2 to +2, and the oxygen saturation is around 95%. And these are the millimeter mercury values, and if we want to convert it to kPa, we can just multiply the millimeter of mercury by 7.5 and we'll get the kPa. So we'll talk about the basic disorders of acid base. So what is acidosis? So it's simple. If the blood becomes acidic, we call it acidosis. What is alkalosis? If the blood becomes alkalotic than the regular value, we'll call it alkalosis. So what is respiratory acidosis? There will be less, the pH will be less than the normal, so less than 7.35, and it's because there is increased carbon dioxide in the blood. So we'll call it respiratory acidosis if the pH is low and the carbon dioxide is higher than normal. What are the causes? So any cause that retains carbon dioxide in our body, that causes respiratory acidosis. So COPD is one of the prominent cause. Severe asthma, drug overdose, any respiratory arrest, airway obstruction, all these can cause respiratory acidosis. Drug overdose means opiate drugs or muscle relaxant, those kind of drugs that depresses respiration that can cause acute respiratory acidosis. Metabolic acidosis. What is metabolic acidosis? If the pH goes down because of metabolic cause, we call that metabolic acidosis. Mostly it is caused by failure of kidney function or loss of bicarbonate. Failure of kidney to excrete acid, so that's one of the prominent cause. Like in renal failure, we can have metabolic acidosis. And loss of bicarbonate can happen in many ways. And there is another cause if there is excess production of acid, like in sepsis, there is production of lactic acidosis. Or in methanol poisoning, there is formation of formic acid, which causes severe metabolic acidosis. So in metabolic acidosis, we find the pH is low, but the bicarbonate is also low. So in a case of metabolic acidosis, we will find low pH along with low bicarbonate. So that we will call metabolic acidosis. There's another term, anion gap. The anion gap is very useful in case of metabolic acidosis. The calculation of anion gap, theoretically, we will add up sodium and potassium and we'll subtract bicarbonate and chloride from that. But in practical arena, what we do, we omit the potassium. So what we do is like we calculate it by subtracting bicarbonate and chloride from the sodium values. The normal range is between 10 to 14. It can vary from lab to lab. So we'll take 12 as a normal value for the sake of calculation for today's purpose. So what it does, it divides the acidosis, metabolic acidosis, in two parts. One is increased anion gap acidosis. The other one is normal anion gap acidosis. The purpose of dividing these two is to figure out why the acidosis happened. So if there is an increased anion gap, it can be caused by DKA, renal failure, lactic acidosis, some poisonings like salicylate, ethylene glycol, or methanol poisoning. Normal anion gap acidosis is mostly caused by bicarbonate loss, like in chronic diarrhea or ileostomy, Addison's disease, if there is a pancreatic fistula, and it can also happen in renal tubular acidosis, where the kidney fails to reabsorb bicarbonate and it loses the bicarbonate. And these are the main causes, but these lists are not exhaustive, and there is so many mnemonics to remember this anion gap and non-anion gap acidosis available in the internet. Then we'll talk about respiratory alkalosis. So in this case, you can understand the pH will be high, so the blood will be alkalotic than usual, and the carbon dioxide will be low. So in a case of respiratory alkalosis, we will find a high pH and a low carbon dioxide. So cause of the respiratory alkalosis. If we breathe more than usual, we'll have respiratory alkalosis. So any cause of hyperventilation will lead to respiratory alkalosis, like panic disorder. In case of pain, we can develop respiratory alkalosis. Pregnancy leads to a physiologic respiratory alkalosis. Acute anemia, salicylate overdose in the first few hours when the salicylate stimulates the respiratory center. At that time, we will have a respiratory alkalosis. Next, metabolic alkalosis. If we have an increased plasma bicarbonate and an increased pH, we will have metabolic alkalosis. So most of the time, it's caused by loss of acid, like in vomiting, or it can be caused by diuretics when we retain more bicarbonate and the acid is lost. The causes are, as I was talking, that loss of acid from stomach or kidney, hypokalemia that can cause to lead to metabolic alkalosis, excessive alkali intake. It was very common previously when alkali was used to neutralize the stomach acids, and contraction alkalosis in diuretics or hypovolemia. So these are the main causes. So the basic changes in various disorder, if the pH goes down and the bicarbonate goes down, that is metabolic acidosis. So the primary disorder is bicarbonate is going down. For that, the pH is going down. we'll find carbon dioxide is also low. That's a compensation. So the compensation means the carbon dioxide is excreted more from the body because the lung is trying to keep the pH in the normal range, and it's trying to get rid of the acid that it can get rid. Respiratory acidosis. So acidosis will have a low pH, and in this case, the carbon dioxide will be higher. So that's the primary cause. The carbon dioxide is going high. And the kidney will try to retain more bicarbonate, and it will try to get the pH back to near normal. So in respiratory acidosis, we'll have a low pH, high carbon dioxide, and high bicarbonate. In metabolic alkalosis, the primary disorder is more bicarbonate in the blood, and the pH will go up also. And for that, the lung will try to retain more carbon dioxide as a compensation, and it will try to bring down the pH to normal range. In respiratory alkalosis, the primary disorder is we are getting rid of carbon dioxide by hyperventilating, and the pH is going up. And the kidney will try to get rid of bicarbonate. The bicarbonate will be low to trying to get the pH back to near normal. So we'll look at the pH first, then we'll look at the other two values, and we'll determine what is the primary disorder. So that's the first step of assessing acid-base disorder in a ABG value. So it can be simple. Simple means only one disorder, or it can be mixed. Like we can have a metabolic acidosis, and we can also have a respiratory acidosis at the same time. But we cannot have a respiratory acidosis and respiratory alkalosis at the same time, because we cannot breathe more and less at the same time. So these two disorders will never coexist. All other combinations of the primary 4 acid-base disorder is possible. So we'll talk about how to analyze ABG. So that's a major thing we'll do. So what we have here, that we have two components of the ABG. One is oxygenation, and the other one is ventilation. So we'll more concentrate on acid base, the second component, in today's lecture. And we'll need serum electrolyte values to analyze that, as I told before. So for assessing the gas status, we can look at the oxygen. So normal oxygen values is 80 to 100. We'll not talk about this today. And normal pH, as we talked about, that is from 7.35 to 4.5. And below 7.35 is acidemia, and more than 7.45 will be alkalemia. PCO2 normal range is 35 to 45, and if more than 45 there is hypercarbia, less than 35 is hypocarbia. Bicarbonate normal value is 22 to 26, and in acidotic metabolic acidosis it will be low, and metabolic alkalosis it will be high. So we'll try to explain it simply and understand it simply also. So how we are going to analyze, we'll be talking about some steps, and you can just take note of the steps, and we'll go through some examples after that. So is there is a significant degree of lung injury or hypoxia? That's the first thing we should look at, and we'll not be talking about that today too much. So if there is hypoxia, we are supposed to correct it in the beginning. So ABC, airway, breathing, circulation, we are looking at those things, and we are correcting any hypoxia if the patient has it. So step 1, we'll do the oxygen assessment, determine oxygen status, correct if needed. Step 2, we'll look at pH. So if the pH is low, it's acidosis. If the pH is high, it's alkalosis. It's as simple as that, and we don't have to think anything beyond this when we are looking at the pH. Step 3, we have to determine the primary disorder. If it is acidosis, then we have to look at the bicarbonate and carbon dioxide. Then we have to determine whether it's a metabolic acidosis or a respiratory acidosis. Then we have to calculate the compensation. But we have to keep in mind that the compensation never overshoots. So if there is a respiratory acidosis, it will be compensated by the kidney, and it will definitely retain more bicarbonate, but the compensation of the kidney will not make the blood alkalotic ever. If there is a alkalosis along with a respiratory acidosis, we'll think about two separate disorders rather than compensation. And there are some limits of compensation. We cannot compensate everything. So we have to also know the limits of compensation, that how much we can compensate for the disorders. And we have to calculate the compensation, and we have to know the limits. So we have to determine first that if there is a compensatory mechanism working, and we'll try to correct trying to correct the pH. So for example, if there is a primary respiratory acidosis, we will have an increased carbon dioxide and a decreased pH. And for the compensation, the kidney will retain bicarbonate. So we'll figure that out, how to calculate how much bicarbonate will be retained for how much carbon dioxide that is retained in the blood. Step 4, compensation calculation for metabolic acidosis. So there is a formula, we call it Winter's formula. So in metabolic acidosis, we all know that bicarbonate will be low. And for the compensation, the carbon dioxide will also be low. So we have to just calculate by the Winter's formula. So we have to look at the bicarbonate. We have to multiply it by 1.5 plus 8 plus minus 2. So that will be the compensation calculation for metabolic acidosis. Suppose in a metabolic acidosis, if the bicarbonate value is 16, so our expected PCO2 will be 16 into 1.5 plus 8. So it will be 24 plus 8. So 32 plus minus 2. So the range will be 30 to 34. So for a metabolic acidosis who has a value of bicarbonate of 16, we will expect the carbon dioxide value in the ABG somewhere between 30 and 34. If it is less than 30, there is a coexisting respiratory alkalosis, because the lung eliminated more carbon dioxide that it should do. And if the value is more than 34, then we'll think about coexisting respiratory acidosis, because the lung is retaining more carbon dioxide than it should do that. Our next calculation is for metabolic alkalosis. So in metabolic alkalosis, the primary disorder is retention of bicarbonate. So for each 10 millimole change in the bicarbonate, there will be a PCO2 change in 6 millimeter mercury. So we'll just calculate those when we'll have a metabolic alkalosis. So these metabolic component alkalosis, the compensation is done by the lungs, and there is no acute or chronic. Any compensation by lungs takes within few minutes, and the compensation is complete within few minutes. So the compensation in metabolic disorders is only a single compensation. On the other hand, if the primary disorder is from lung, the compensation will be done by the kidney, and it will take several hours to get completed. So there will be two kinds of compensation. One is acute and another is chronic. So the difference between acute and chronic will be 72 hours. So if there is a acute respiratory insult, the kidney will compensate fast, and it will not compensate much in the first 72 hours. But by the time that 72 hours is crossed, the kidney will get enough time to get it completed. So in the beginning, for respiratory acidosis, for acute respiratory acidosis, for retention of each 10 millimeter of carbon dioxide, we'll have a bicarbonate change by 1 and a pH change by 0.08. For chronic changes, for 10 millimeter of mercury carbon dioxide retention, kidney will compensate more and it will retain 4 millimole of bicarbonate and the pH change will be less. So it will be 0.03. Same for the respiratory alkalosis. For acute, change of 10 millimeter of carbon dioxide will lead to change in 2 millimole of bicarbonate. And the pH will change 0.08, same as acidosis. And for chronic, the change will be 4 millimole of bicarbonate for each 10 millimeter mercury of carbon dioxide, and the pH change will be 0.03. So here, I used to remember it like this, 1, 4, 2, 4. That's the changes in bicarbonate we are going to expect. So for acute respiratory acidosis, bicarbonate will be changed or increased by 1 millimole. For chronic, 4 millimole. For respiratory alkalosis, it will be 2 millimole, and chronic respiratory alkalosis, it will be 4 millimole. So that was the fourth step. Our fifth step is calculating the anion gap. So for practical purpose, sodium minus chloride plus bicarbonate is the anion gap. And the normal value is around 12. For my lab, it's 12. Then we'll calculate the delta gap. So what is the delta gap? It's the patient's anion gap minus normal anion gap. So which will be 12 for this lecture purpose. So most of the labs, it will be 12. For your lab, you have to ask your biochemist that whether it's 12 or 10 or 14. Then we have to talk about corrected bicarb also. So the patient, the corrected bicarb is patient's bicarbonate plus this delta gap. If the corrected bicarbonate is more than 24, then we'll think about there is a coexisting metabolic alkalosis. And if the corrected bicarb is less than 24 or less than normal, we'll think about a coexisting non-anion gap metabolic acidosis. So in respiratory acidosis, we'll give some example and we'll run through this together. So for respiratory acidosis, you can see this example, the pH is low. So this is a acidosis. And why this acidosis occurred? Because the carbon dioxide, which is supposed to be 40, it's more. So this is a primary respiratory acidosis. For respiratory alkalosis, this is high pH. So it's alkalosis. And why this happened? If we look at the carbon dioxide, it's less. So it is a respiratory alkalosis. If we look at the bicarbonate, it's low. So there is some compensation for this. So for this one, look at the values. 7.3 is acidotic. Carbon dioxide is near normal. Bicarbonate is low. So this is a metabolic acidosis. This one, pH is high, so it's alkalosis. Carbon dioxide is near normal. Bicarbonate is high. So it's a metabolic alkalosis. So we'll go through some cases. So it's a 27-year-old male with type 1 diabetes and arrived in the emergency, and room air, we got ABG. So if we look at the ABG first, it's a 7.25, which is, so it's a acidosis. So what kind of acidosis this is? So if we look at these two values, the carbon dioxide is low and bicarbonate is also low. So pH low, bicarbonate low, carbon dioxide low. So this is a metabolic acidosis. So if we look at the electrolyte values, sodium 140, chloride 104, and the bicarbonate or TCO2 is 8. So we can, from here we can also say that it's a metabolic acidosis. So as we talked about, it's a metabolic acidosis. Our expected CO2 that we'll calculate by the Winter's formula. So the measured bicarb into 1.5, so that is 12 plus 8, so that is 20. So our expected carbon dioxide or PCO2 will be sorry, somewhere between 18 and 22. So if we look at the value here, it's 22. So this is a metabolic alkalosis, acidosis, which is well compensated. So if we look at the anion gap now, the anion gap here is 28. So the normal gap is 12. Here the anion gap is increased. So what is our next step? Is to calculate delta gap. So delta gap is 28, which is patient's anion gap, minus normal gap, which is 12. So delta gap is 16. And then we have to calculate the corrected bicarb. So the corrected bicarb is patient's bicarb, which is 8 plus the delta gap, 16. So the corrected bicarb here is 24, which is perfectly normal. So here we have a compensated anion gap metabolic acidosis. And what could be the cause here? The patient is a type 1 diabetes and a young male. So possibly he missed his insulin or something like that and developed a diabetic ketoacidosis. So that could be a cause in this case study. So we'll go to the second case. A 17-year-old female who had a road traffic accident, not a renal tubular acidosis, was unhurt but developed carpopedal spasm. The police brought the patient to the emergency room because of the carpal spasm. So what we did a ABG. So in this ABG, we can see the pH. So how is the pH? It's alkalotic. So this is alkalosis. So what kind of alkalosis we have here? So if we look at the carbon dioxide, it's low. So it's possibly a respiratory alkalosis because the patient is eliminating more carbon dioxide and the blood became alkalotic. So it's a respiratory alkalosis. So for each 10 millimole, we will be talking about the compensation now. So for each 10 millimole change in the bicarbonate, here the change is 16. So for the sake of calculation, we took it as 15. The decrease in PCO2, the expected pH in acute case is 7.52. So that is 7.4. The change for acute case is 0.03. So 0.08. So for 15, it will be 0.12. So the expected pH is 7.52 in acute respiratory alkalosis. That's happened here. And the bicarbonate is little low. So that's all we want to know here. So the compensation is good and it's a acute respiratory alkalosis in this patient. And why it happened? Because of the panic that the patient had in the RTA. So we'll go through the third case now. So the third case is a 55-year-old male who presented with a abdominal pain and nausea, vomiting, and shock. The patient was diagnosed with pancreatitis. So if we look at the pH, so what is the pH here? 7.25, which is less than normal. And that's the acidotic pH. And why the patient had acidosis here? Because bicarbonate is low and PCO2 is also low. So it is a metabolic acidosis. So it's acidosis and it's a metabolic one. So what's the next step? We are going to calculate the expected PCO2, the Winter's formula that we talked about. So the measured bicarbonate into 1.5 plus 8. So here it's 18 plus 8, so 20, and the result is 26. The range is 24 to 28. So that's the expected PCO2. So if we look at the PCO2 of the patient, it's 20. So it's less than the expectation. So there is a coexisting respiratory alkalosis. The patient exhaled more carbon dioxide than the patient supposed to. Now we are going to calculate the anion gap. So the anion gap is 29 here. So it's more than normal. So it's a high anion gap metabolic acidosis. And then we are going to calculate the delta gap. So the delta gap is 17 here. We got it from 29, which is patient's anion gap, minus normal anion gap, which is 12. And we are going to calculate the corrected bicarb, that is 17 plus patient's bicarb. So that is also 29. This is more than the expected value of 24. So there is a coexisting metabolic alkalosis also. So what are we having in this patient? In the beginning, we saw metabolic acidosis, then we saw respiratory alkalosis, and then we also saw metabolic alkalosis. So this is a mixed disorder. So what are the things? Anion gap metabolic acidosis with respiratory alkalosis and with metabolic alkalosis. So this is the analysis of the ABG. But as a clinician, we have to figure out why all this happened. So if we look at the case, the patient had abdominal pain. So the pain is possibly from the pancreatitis, and the patient also had shock. So possibly the shock led to lactic acidosis and that led to anion gap metabolic acidosis. And why the respiratory alkalosis? Most likely it's from the pain. The patient is hyperventilating and the patient had respiratory alkalosis. Why the metabolic alkalosis? If we look at the vomiting, possibly the patient vomited out all the stomach acid and the patient developed metabolic alkalosis. So our job is to figure out why the patient is having all these things and determine how to correct all those things. And our aim will be to correct the underlying pathology, and then we'll go from there. So take-home messages are: valuable information can be gained from an ABG as to the patient's physiological condition. ABG analysis is only part of the patient assessment, and we have to figure out why the ABG changes happened, and we should be systematic with our analysis, and we should start with the ABCs as always and look for hypoxia that can be also treated quickly, then follow the steps completely, and we should not assume what the patient is having. So that's the acid-base basics, and it's not that all of us are very smart, but it's just that we stay with the problem a little longer. So I would ask you to stay a little longer with the ABG, learn it by heart, and practice it. If I don't practice it for a few months, I'll also forget analyzing the ABG. So we have to practice the ABG. Thank you for now, and I have some more example. I would also like to share some of those examples with you right now. It will take only a few minutes. Okay. So we have a 1-year-old woman. The patient presented with confusion, fever, flank pain, and the patient is breathing heavy. So that means Akushmal breathing. And the patient known to be diabetic. So this is the style that we write up. So this is the pH, 7.32. So what is it? It's acidosis. So primary disorder, we are seeing the carbon dioxide that's low, and we are seeing the bicarbonate here that's also low. So it is a metabolic acidosis. So we have to calculate the compensation. So what is the expected carbon dioxide here? 14 into 1.5. So that is 21 plus 8. So 29. So it's 28 plus minus 2. There's a range. So it's okay. So it's a compensated metabolic acidosis. The anion gap here is 140 minus summation of these two. So that is 22. So expected bicarbonate, if we calculate 22 minus 12, that is 10, and patient's bicarbonate, that is 14, it is 24. So that's also okay. So it's a pure anion gap metabolic acidosis. So why it happened? It's a woman who is diabetic. The patient is 21-year-old, possibly sexually active. The patient presented with fever, flank pain, and breathing heavy. So it's a classic case of acute pyelonephritis. So it's a decay with pyelonephritis. So this kind of scenario is very common in exams, and we can analyze all those things just from the ABG and electrolyte data. So another case, a 8-year-old man present with 4-day cough, diarrhea, and the chest X-ray is showing left lull of infiltrate. Patient breath smells of alcohol. So what we have here? We have a pH of 7.31. This is the carbon dioxide, that is 10. And we have a bicarbonate, that is 5. So what is the primary disorder? Metabolic acidosis. So if we are calculating the expected PCO2, the compensation, by Winter's formula, so it comes down to 15 around, so that there is carbon dioxide is 10 in the patient. So the patient is exhaling more carbon dioxide than he is supposed to. So there is a concurrent respiratory alkalosis. What is the anion gap? Anion gap is 19 here, and expected bicarbonate is 10. So there is a non-anion gap metabolic acidosis also. There's a slight mistake, so it should be 7 plus 5, so it will be 12. It doesn't change the interpretation, and there's a non-anion gap metabolic acidosis. So the patient has anion gap metabolic acidosis that we calculated first. The patient also had non-anion gap metabolic acidosis and respiratory alkalosis. So why this patient had all these things? Possibly the patient had alcoholic ketoacidosis or methanol poisoning that can cause to metabolic acidosis also. Patient had diarrhea and pneumonia. So possibly it's a aspiration from the drowsiness of the alcohol that can happen, or it can happen in an atypical pneumonia that also cause some diarrhea. So the ketoacidosis is the anion gap metabolic acidosis. The diarrhea caused metabolic alkalosis, and the pneumonia caused respiratory alkalosis. So we have to explain all those things when we are analyzing the ABG, and we have to correlate with the clinical context. Another 58-year-old man with 4-day cough, vomiting, and altered mental status. Same case almost. The pH is high, so it's alkalosis. And the carbon dioxide here is low. So it's a respiratory alkalosis. So that's the first step we did. So if we calculate the anion gap here, so the anion gap is also 30. So there is a concurrent metabolic acidosis. But the primary disorder, as it is a alkalosis, we have to tell that it's a primary respiratory alkalosis with concurrent metabolic acidosis. So for a primary respiratory alkalosis, we will be correcting the bicarb, or we'll be calculating the compensation. So it will be expected bicarb here is from the 20 value, the correction is 33. So that there is a concurrent metabolic alkalosis also. It should be 24 if it is a normal correction. So this patient has a respiratory alkalosis, this patient has a metabolic acidosis, and also has a metabolic alkalosis. So the respiratory alkalosis happened from the pneumonia, and metabolic acidosis may be from diabetes and vomiting. Another case, a 40-year-old male, is a mountain climber and got labs done after 3 weeks of a 15,000 feet base camp arrival. So the patient reached there, and after 3 weeks, the patient got calculated of this ABG. So the patient had a 7.44 pH. So this is in the higher range but near normal, maybe a little alkalotic, and the carbon dioxide is little low. So this is a respiratory alkalosis. So there is a 15 decrease in the PCO2. The normal should be 40. So for 15 decrease in PCO2, the pH change we expect is around 0.04, because for each 10 there is pH change would be 0.03. So it should be 0.045 actually. So here, if we calculate that, if we take normal as 7.4, the pH change is 7.44, which is perfect. And the next step, the expected bicarbonate for 15 decrease in PCO2, we are expecting a 6 drop in the bicarbonate in a chronic case. So in this case is chronic because he is staying in the base camp for 3 weeks. So the 6 drop in bicarbonate is 24 minus 6, that is 18. Then we are going to calculate the anion gap. It's normal, within normal range 10, and there is no acidosis. Although the bicarbonate is low, it's from the compensation, it's not a primary acidosis. So this case is a well compensated respiratory alkalosis. So hyperventilation with chronic respiratory alkalosis, which is compensated. Another example, a 56-year-old female with known stage 4 chronic kidney disease came to emergency with shortness of breath. On exam, the patient is tachypneic, normal lungs, no fever, chest X-ray is also normal. So when we assess the pH, it's acidotic. If we look at the carbon dioxide, it's low, and the bicarbonate is also low. So it's a metabolic acidosis. So we are going to calculate the compensation now. The bicarbonate is 16. 16 into 1.5 will be 24 plus 8. So it will be 32. So 30 to 34 is the expected carbon dioxide. So the patient has 30. So it's a well compensated metabolic acidosis. If we are calculating the anion gap, it's a it's 9. So the anion gap is low. So it's a non-anion gap metabolic acidosis. So we have a non-anion gap metabolic acidosis with respiratory compensation. So this is a renal tubular acidosis from CKD, which led to non-anion gap metabolic acidosis. Another case, a 35-year-old woman with diabetes who presented as an upturned patient. So if we look at the pH, it's a acidotic pH. We also have high carbon dioxide. So it's a respiratory acidosis. So anion gap, if we are calculating anion gap, it's 30, 145 minus 100 plus 15. So we have concurrent primary metabolic acidosis. So what we have here, respiratory acidosis and anion gap metabolic acidosis so far. So our expected bicarbonate in this case will be 33. So there is concurrent metabolic alkalosis. The calculated expected bicarbonate is 33. So we have another component, metabolic alkalosis. So we have respiratory acidosis, metabolic acidosis, and metabolic alkalosis here. So what could be the case? Possibly hypoventilation that led to the high carbon dioxide, and hypoventilation due to altered mental status. The patient may have decay and may have vomited that led to the other two causes. Another one, a 60-year-old male recently discharged from the hospital for treatment of aspiration pneumonia, and he was discharged with levofloxacin and clindamycin. 1 week later, he presented to the emergency room with severe diarrhea, abdominal pain, and hypotension. So what we have here is acidosis, low bicarb, low carbon dioxide. So it's a metabolic acidosis. So what is the next step? Calculating the expected PCO2, the Winter's formula. So 10 into 1.5 plus 8. So it's 23. So 21 to 25. So we have a well compensated metabolic acidosis. So what's the Anion gap? 99 plus 10. So 109. So Anion gap is 20. So what is the delta gap? 20 minus 12 is 8. So what is the corrected bicarb? 10 plus 8, 18, which is lower than the normal. So we also have a non-anion gap metabolic acidosis. So what we have here? We have a anion gap metabolic acidosis with proper compensation, and also have a non-anion gap metabolic acidosis. So that's the case. So why it happened in this patient? So possibly it's a septic case from Clostridium difficile that was precipitated by the antibiotic levofloxacin and clindamycin, and the diarrhea that led to non-anion gap metabolic acidosis. This is possibly the last example. A 42-year female presented with flaccid paralysis, also complaints of blurring or burning eyes and swallowing difficulty as mouth feels dry. The patient has pH of 7.32, so this is acidotic. The patient also has low carbon dioxide and low bicarb, so it's a metabolic acidosis. The patient also has low potassium here. So the expected carbon dioxide is 30 to 34, which is well compensated. We all know the calculation, the Winter's formula. Then we are going to calculate the anion gap. So the anion gap is low. So it's a non-anion gap metabolic acidosis with a proper respiratory compensation. So what's the case? The patient also has hypokalemia. So hypokalemia, we usually expect alkalosis, but this one is acidotic. So it's pointing towards renal tubular acidosis possibly. The patient presented with flaccid paralysis, that's from the hypokalemia. This burning eyes and swallowing difficulty is possibly from xerostomia and xerophthalmia, possibly from Sjogren syndrome. So this case is possibly a renal tubular acidosis with Sjogren due to Sjogren syndrome. So it's a type 1 RTA with hypokalemic paralysis secondary to Sjogren syndrome, and the patient tested the antibodies positive. Oh, there's another one.
Sorry to
Sure.
sorry to interrupt you. There are lots of questions, so I think we should move to question answer session.
Sure. So I think this is the last one. That's it. So I'll be just closing the session. Thank you, and we'll be moving to the question answer session. Thank you.
Thank you so much, sir, for this amazing presentation. Now it's time for the question and answer session. These are the questions that you asked during the live session in the comment section. Let me request Dr. Tamanna to start the question and answer session. Dr. Tamanna.
Thank you, Dr. Raihan Rabbani, sir, for this amazing presentation. Hope you all enjoyed this presentation and learned a lot. Arterial blood gas analysis and acid-base disorder is very important for all type of exams and also for practical purpose when you are treating a patient. Now, this is the time for question answer session. And we can see that there are many questions that were sent to us during the presentation. I'm not sure if I can cover it all, but let's start the question answer session now. First question is from Dr. Mohammad Bahauddin Kawser, and he asked how to differentiate venous blood gas from arterial blood gas. And almost same type of question is asked by Dr. Noshin Tabassum. She asked, can you substitute arterial blood with venous blood for blood gas analysis?
So the arterial blood gas analysis, if we are going to prick the artery, we are getting the actual values. So that has some importance. So if we are trying to look at the pH, only the pH, then venous blood gas is good enough. So we can substitute in some cases for the arterial blood gas with the venous blood gas. But in the beginning, we should do the arterial blood gas. So when we are doing the arterial blood gas, when we are taking the sample, we also should note the SpO2, the pulse oximeter, how is the saturation, oxygen saturation. And we should compare it with the SO2 when we are getting it from the arterial blood gas machine. So by comparing that, we'll be knowing that the patient's clinical status, and we'll be knowing whether it's an arterial or a venous blood gas. So that's the thing we should look at. And in general, in arterial blood gas, the oxygen values will be in the higher range, and in the carbon dioxide will be in the lower range. In venous blood gas, the oxygen will be low, and the carbon dioxide will be little higher than the arterial value. But as we are doing it in sick patients, this doesn't make much sense, because oxygen will be low in a hypoxic patient, and you can just say because of the oxygen is low, it's a venous. That cannot be said unless you see the patient and unless you know the SpO2 when you are taking the blood.
Okay, thank you, sir, for your answer. Then next question is from Dr. Saba Saleh, and she asked, how can we understand partial compensation of metabolic acidosis and metabolic alkalosis?
So we talked about the metabolic acidosis and metabolic alkalosis. These are compensated by the lung mechanism. So there is no acute or chronic or no partial or complete. So in case of primary metabolic disorder, the compensation will take place within minutes, and it will always be complete. So if there is not a complete compensation, that as she was trying to tell, so we'll be thinking about coexisting other disorder. Like if we are seeing that there is a more carbon dioxide than we expect, so there is a coexisting respiratory acidosis. So for metabolic disorders, the compensation is only one compensation, no acute or chronic. On the other hand,
okay,
if we are thinking about primary respiratory disorder and it's compensated by the kidneys, we did the calculation. In acute, the pH change will be more. In chronic, the pH change will be less. We know the calculation. And if it is somewhere in between, we'll call it a partial compensation.
Okay, thank you, sir. Now, the next question is from Dr. Farhana Alum, and she asked that, is there any role of liver in acid-base disorder?
Liver and every organ has role. So liver, what liver does, it metabolizes the lactic acid. So if there is a lactic acidosis and the liver is not functioning properly, we'll get more acidotic very rapidly. So that's the only role that liver can play. But in direct balance of the pH, the liver doesn't have much role.
Okay, the next question is from Dr. Minhaj Korim. I think the question is already answered by sir by an example. Can the type of renal tubular acidosis be detected from an ABG report?
No, it's actually ABG will say that it's a metabolic acidosis, and some ABGs, we can look at the base excess and we can tell that it's a non-anion gap metabolic acidosis. But it will not point towards the cause. In the ABG machine, we may have a electrolyte value and we can see hypokalemia there, and we can say that it's a hypokalemic non-anion gap metabolic acidosis. But it can happen in so many cases that we have to correlate clinically. We also have to look at the urine pH value to say that it's a renal tubular acidosis.
Okay, next question is from Dr. Kawser, and he asked, how important is it to send a serum electrolytes simultaneously with arterial blood gas analysis?
If we are trying to analyze the acid-base disorder completely and properly, we all must have a electrolyte value, because the bicarbonate value that we get in the arterial blood gas report, it's not measured, it's calculated, and it can be false in some cases. In electrolyte values, we have to have the bicarbonate value that is measured, and we also have to have the sodium and potassium value to calculate the anion gaps. So for a complete analysis, you always need a almost concurrent electrolyte value.
Okay, I will take two more questions. Dr. Tasneem Hussain asked, in general ward settings, how frequently should we repeat arterial blood gas analysis if found abnormal?
That depends on the abnormality we found. So in general ward setting, maybe we can do a arterial blood gas to figure out whether the patient is hypercapnic or not, how much degree of acidosis the patient has. If it is severe enough, the patient should go down to ICU or HDU. So in those cases, what we need to do, if it is severe acidosis or severe alkalosis, we will be taking the corrective measures, and then we will repeat the arterial blood gas depending on the corrective measures, maybe every 2 to 3 hours. In case of ventilator adjustment that we do frequently in the ICU, it can be repeated as early as 15 minutes to somewhere between 2 hours. But in practically, if it is a very severe case, we do it from somewhere between 30 minutes to 2 hours if needed.
We all know that the normal range of partial pressure of oxygen is 80 to 100 millimeter mercury. But what is the threshold of partial pressure of oxygen below which we can call it hypoxia? It is 80 millimeter mercury or 60 millimeter mercury?
Below 60, below 80 or is hypoxia. Normal is 80 to 100. But if it goes beyond 60, then it becomes clinically significant. So if we are looking at the pulse oximeter, the percentage that we are talking about, if it is 92%, that usually corresponds to the 60 millimeter of mercury. If it is 88%, that corresponds to the 55 millimeter of mercury. So in a case of hypoxia, we like to supplement oxygen when it goes beyond 92% or 60 millimeter of mercury. Above that, we don't need to supplement unless it's a special case. But the 60 millimeter is not normal, it's hypoxic. But you don't need to supplement oxygen for those cases.
Okay, that was a wonderful discussion, sir. And thank you for your wonderful answer. It's time to conclude the question answer session here because of the time shortage. Now I'm moving to our both panelists for their comments. I would like to start from Professor Golam Kibria, sir. Professor Golam Kibria, sir.
Can you hear me?
Yes, sir.
I'm sorry.
Can you hear me?
Yes, sir. You can be heard, sir.
Sir, you have muted yourself, sir. Please unmute.
Okay.
Yes, we can hear you now. Sorry, you have muted again.
Are you hear me? Thank you very
Yes,
much.
sir.
Thank you very much. Thank you to the Professor Nazmul Hasan, chapter Recipe Bangladesh chapter, and to Professor Haji Tariqul Islam, ex-governor, and Professor Khan Abul Kalam Azad, governor-elect, for selecting me as a panelist of this prestigious presentation done by our future renowned doctors Raihan Rabbani. I think he was very much known to me when I was in my mission. He was showing his potentiality from the beginning of his study. He has excellently presented these difficult topics in a simplified way, which is very much helpful for the clinician to understand how to do the ABG and calculate the values to correct whether correction is required or not. And excessive correction will be a fatal one. If it is corrected timely, it will save the life of the patient. And I think it will be very much beneficial for the listener who has attended this session. He has clearly, elaborately explained all the things. Nothing is required to explain again. And I thank him again, and also the Choyti, Dr. Tabassum, who has excellently moderated this session, and also the Prince, who is the maker of this screen, behind the screen. Thank you very much for selecting me as a panelist. I thank all the participants and also the speakers, especially the Raihan Rabbani. Thank you very much.
Thank you, sir, for your valuable opinion. It's always great pleasure for us to hear from you. Now, I would like to request Dr. Ahmed Mursel Anam, sir, for his comment regarding the session and topic.
Thank you, Dr. Choyti. My respected teachers, my consultant, Dr. Raihan Rabbani, and learned audience, Assalamu alaikum. This is not the first time I have attended this lecture by Dr. Raihan Rabbani. This is probably the 6th or 7th time. And every time I get amazed how simplify one can make this relatively very hard topic. I work in the critical care for at least last 15 years, and still I get confused with ABG. And Raihan Rabbani sir always makes it so clear. So I must congratulate and thank again. I also would like to take this opportunity to thank the organizers for selecting me as a panelist. I'm not sure whether, being a disciple of Dr. Raihan Rabbani, I should be in the panelist seat and he's the presenter. It should have been the other way around, I think. But again, thank you very much. And also thank you, Professor Nazmul Hasan sir, for giving me this opportunity. I thank everybody and thank again. Thank you very much.
Thank you, Dr. Ahmed Mursel Anam, for your wonderful opinion. Now, I'm moving to our chairperson tonight, Professor H.A.M. Nazmul Hasan sir. Sir, please share your valuable opinion and comments regarding the presentation and the topic. And along with this, we are going to conclude this session. Thank you for your patient sharing and spontaneous participation. Sir, please give your comment.
Thank you, Dr. Choyti. It is difficult to memorize your full name. It is very easy for me to say Choyti. At the beginning, I must congratulate Dr. Rabbani for your outstanding presentation. And we are running this episode as acute health problems, acute emergency, acute medicine. And we are trying to select around 25 to 30 topics. I think out of all topics, this acid-base disorders and interpretation of ABG is possibly one of the most difficult topics. And we were discussing to whom we will give. Almost everyone said that Dr. Rabbani is the appropriate person to give a presentation on this. So you are so renowned. I feel actually proud for you. Uh, you have shown your reputation. Dr. Anam has already said he's working with this for last 15 years. Still, he sometimes becomes confused. So when one memorize respiratory acidosis, sometimes it is easier. When one read respiratory alkalosis, it is sometimes it becomes difficult. And when one starts reading all four things, sometimes it becomes clumsy. So without practicing this, it is very difficult. So Dr. Rabbani has said that we are to practice this acid-base balance and interpretation of ABG. Without that, it is sometimes very difficult. Regarding the topic, I will say, as a doctor, we can see very closely from life of the patient how amazing is our body, how closely the pH is maintained between 7.35 to 7.45, how lungs, how kidneys, they are making balance of these hydrogen ions and bicarbonate ions. So this our body is actually is really a surprising and amazing thing. And functioning the body, we have to say Alhamdulillah to Allah. So I must congratulate Dr. Rabbani once again for making the topic very simple and understandable. I think everyone, those who have listened, who have the opportunity to listen this topic, they all will be benefited. Even I have also learned many things from today's presentation. I will also congratulate the two panelists, our senior most Professor Golam Kibria and Dr. Anam. They have contributed also. They have said that this is a very important topic. I know Dr. Chaudhury, he is a very energetic academician and clinician, and for our good anchoring. Dr. Prince, he is always with us. And behind the scene, Professor Rubina Yasmin, she is organizing this whole topic. So I must congratulate and give thanks to Professor Rubina Yasmin from SCP Bangladesh chapter. I request all the participants for next to listen to our next topic. Thank you to the speaker once again. With this, I must conclude this here. Thank you. Thank you. Yeah.
Sadly, we have come to the end of today's program. We have learned so many essential things about the management of acid-base disorder from Sir today. Many, many thanks to the speaker, the chair, the panelist, and last but not the least, the moderator Rapu for managing time for this program from their very busy schedule. I would like to thank all the audience who were with us throughout the event, especially those who asked the questions. If you joined late or couldn't see the whole program, there is no need to be worried. You will find the whole program on YouTube after the live session finishes. Our next health talk on acute medicine will be held on 22nd of December. So, see you all in the next episode. Until then, take care and good night.